trials, little is known about the rate of progression and the characteristics of such progression at the population at large. So these are the factors associated with the progression from the prediabetes to diabetes: the elevated fasting plasma glucose, or an increase in fasting plasma glucose, a high BMI, weight gain, high plasma insulin, decreased insulin response to glucose, dyslipidemia, hypertension, poor beta cell function, or the choice of treatment. A 2007 study looked at the progression of prediabetes to overt diabetes and observed that 8.1% of its subjects whose initial fasting glucose was 100 to 109, and 24.3% of its subjects whose initial fasting glucose were between 110 and 125 developed diabetes over an average of only 29 months. There was a steeper rate of increasing fasting glucose for those with a higher BMI, blood pressure, and triglycerides, and lower HDL cholesterol than predicted diabetes development. So when asking, does hyperglycemia evolve from normal glycemia gradually over time or in a step increase? A 2004 study concluded that non-converters, or those whose glucose tolerance was normal on the 3 tests over a 7-year study, had only a slight increase in fasting plasma glucose, and converters, or those who had impaired glucose tolerance, showed a large step up in fasting glucose plasma. So within a 3-year time frame, the onset of diabetes is often rapid rather than gradual, and is in part explained by a fall in glucose-stimulated insulin response. Next. So next we'll talk about the acute insulin response. So the natural course for beta cell function suggests that the acute insulin response plays a major role in determining glucose tolerance status over time. The progressive decrease in beta cell insulin secretion, particularly the first phase of insulin secretion that occurs acutely after an increase in glycemia, is likely the most critical function beta cell defect in the development of type 2 diabetes. Normal beta adaptation to insulin resistance can occur through increased insulin secretion from each beta cell and/or an increase in the beta cell mass. Some individuals have a reduced insulin secretion or reduced beta cell mass, but normal glucose levels. They have sufficient insulin sensitivity to endure adequate insulin secretion. In insulin-resistant patients or those with type 2 diabetes, there is an inadequate insulin secretion from each beta cell or an inadequate beta mast cell for the levels of prevailing insulin sensitivity. So when glucose is elevated, the insulin secretion is stimulated and glucose secretion is suppressed. Conversely, when the blood glucose is decreased, insulin secretion should be suppressed and glucagon secretion stimulated. All of these actions are highly glucose dependent and critical to maintain normal glycemia when varying insulin needs. They also provide the classic response to a meal. Although the failing beta cell loses its ability to respond to glucose, not all responses are diminished. Insulin secretions, for example, in response to amino acid stimulation or through stimulations of other hormones, such as glucagon-like peptide 1, is preserved. Beta cells maintain their responsiveness in the face of insulin resistance through increased insulin secretion in response to meals, as well as through chronic response to increasing beta cell mass. Normal weight in other individuals, or other obese individuals, maintain a normal or similar, I can't talk today, 24-hour glucose response to meals. However, the groups differ in mean insulin secretion, which is significantly higher in obese subjects than their normal weight counterparts. In addition, insulin secretion in obese subjects fails to return to baseline between meals. So our next one is progression to medication. The next step in progression could be the need for medication. This aspect of medication is started in reference to an A1C over 7 and is often biased by a physician delay in treatment or patient-related delay in care. 2008 studies showed that indirect evidence that the pathogenesis of type 2 diabetes in subjects who develop diabetes at a younger age is different from that of older subjects and should be managed more aggressively when weight gain is involved. Our next is loss of glycemic control on that medication. So this is where patients feel they have failed or need to realize the progression of diabetes is not primarily related to patient behavior and have other contributing factors. Major clinical trials provide evidence of increasing loss of glycemic control over time in type 2 diabetes. And there was a study called the UK Prospective Diabetes Study that showed that therapy with metformin, sulfonylurea, or insulin substantially lowered A1C and fasting plasma glucose compared to with conventional therapy, but over 11 years increased significantly. Another study showed that in the initial 3 years, non-obese subjects were more likely to require additional therapy than obese patients due to beta cell function, and showed that with lower function, they were more likely to fail. So I think that's important when we talk about type 2 diabetes. We also look, you look healthy, but with the increased amount of weight gain, not only just being obese, but how quickly you gained your weight can also kind of correlate with beta cell function. So the major cause of disease progression and the hallmark of type 2 diabetes is the beta cell function decline. The declining function of beta cells can begin as early as 12 years before diagnosis and continue throughout the disease process. Using the HOMA homeostasis model assessment to quantify beta cell function demonstrates that beta cell function continues to deteriorate in association with progressively increasing hyperglycemia despite treatment. So as beta cell continues to decline, monotherapy failure is almost inevitable. Also in that same study, they showed that A1C will increase 1% every 2 years with most therapies. Patients require repeat and vigorous interventions. So failure to implement such interventions, either to clinical inertia or patient noncompliance, worsening in glucose control and perpetuate a vicious cycle of hyperglycemia and glucose toxicity. Importantly, failure of beta cell function in the late stages of the disease is further compounded by complications of diabetes by the likelihood of significant comorbidities in elderly adults. So data strongly supports a genetic predisposition to beta cell failure, a genetic subtype of disease characteristics by diagnosis at earlier than 24 years of age has been identified and as a common cause of early onset type 2 diabetes. Multiple genetic mutations have been identified, and in some affected individuals, a genetic cause for their disease is recognized. However, in most patients in clinical practice, it is almost impossible to identify a genetic abnormality clinically, and environmental factors predominant. So the last is the natural history of obesity, progressive weight gain. Weight gain is another common concern for type 2 diabetes as it progresses. Patients treated with insulin often experience the greatest weight gain, followed by sulfonylurea treatment. The least amount of weight gain is with metformin and conventional weight loss. The newest class of drugs, GLP-1 agonists, leads to weight loss and can also be prescribed for diseases other than diabetes, such as obesity and primary and secondary cardiovascular management and prevention. Next. Any questions?
Thank you so much. That was a wonderful presentation and very informative. I don't, of course, gather all the information in there, but that's really helpful for me. What kind of questions does everybody have today?
I have to say I do use these words in my patients all the time, as they call me in, they're frustrated and they feel, whatever they've been doing and all of a sudden they have to go up on their insulin. I do use the words, diabetes is a progressive disease, and I, go into a little bit of beta cell functions, but as I read my case study here today, I have to say I have learned quite a bit, so. The article I have linked also gives a little more in depth. It was a little over my head, so I'll let y'all read that on your own.
Absolutely. I'll make sure to put that in the recap. It'll be included with the PowerPoint.
Thank you.
Dr. Giordano, did you unmute? I see that you unmuted. Didn't know if you wanted to.
I thought it was a great overview. I think exactly the same as Cherie, in that we have a lot of patients that work really hard to take their insulin, go to the gym, eat right, and really try to get on the right track. And it's very important to explain that it is a progressively worsening disease. And over time, the natural history is you lose beta cell function. It does not matter if you eat salads all day and you work out all day. It is a progressively worsening disease. And so just hammering in that point so that the patient isn't blaming themselves if they're doing all the right things and taking their medicines properly, I think is really important for communication. That, there are other environmental factors. genetic factors. You know, type 2 diabetes is also genetically linked. A lot of people think it's just type 1, but that's not true. You know, type 2 also has genetic predispositions. And so there's just so many factors, I think, that are out of a patient's control that are important to understand in the progression from pre-diabetes to full-blown diabetes, or even if they have overt diabetes, to a worsening state of their diabetes. Thanks, Cherie. I think that was wonderful.
Thank you.
Yeah, thank you so much. Do you ever, just out of curiosity, do you guys ever have like the opposite effect? If you tell them it's progressive, do they feel like then they can't do anything? And or if it's not, do they feel discouraged ever when that is said to them, that you have to work through as well? Like, still please do all these, exercise, try to eat healthy, but do you ever have like someone feel the opposite of that because it is a progressive disease?
Cherie, I don't know if you're going to answer as well, because I think Cherie and I probably have different perspectives. But certainly I think there is some bit of, discouragement if you do hear that. However, I really do think it's an important tool so that the patient understands that they still can modify their disease outcome. It just may take a little bit of the burden and the pressure off of them to understand that, okay, well, I'm eating right, I'm exercising, and my sugars are still going up, so this isn't entirely my fault. I think it relieves a little bit of burden in that patient. And I feel like that's been my experience. I think certainly it is a little bit of a downer to hear that, but it's an important tool in them kind of learning how to cope, with the disease long term.
I completely can see that too. I mean, I have family members that have it, but I don't think that has ever been said to them that way. So I think that would be beneficial to them because they feel discouraged because they do so much for it. Including so I think that'd be nice to hear, like, okay, I'm doing this stuff, but some of it isn't in my control, and it is just a disease that I have to deal with and manage the best I can. Great point.
And that's very true, but also diabetes has come a long way in the last 5 to 10 years. We have more tools at our disposal, more medications that aren't insulin, the end all be all insulin. So I feel like we do have more tips and tricks, more ways to help our patients now than we ever have.
Such great news too. What other questions or comments does anybody have today?
I noticed we got a couple participants join during the presentation as well. I was thinking maybe we could have them introduce themselves for the group. Donna, did you want to introduce yourself? It's great to see you.
Hello, great to be here. I'm lightening up a little bit, so I might be able to participate again. I always appreciate the education and information we get here and the collaboration. So my name is Donna Buchanan. I work with Population Health. I'm a nurse in that program. Thank you.
Excellent, thank you. It's great to have you again. And Mary Kay actually chatted in saying she doesn't have a mic working today, so no worries at all. She's just listening in. Thank you for joining.
I would add one more additional point that I get a lot of questions often, how do I protect my beta cells, and is there any way to reverse that? It is a common thing. And there is no way at this point to reverse the damage from type 1 and type 2 diabetes. Currently there's ongoing trials to do beta cell replacement, so a transplant of the beta cells. But as of right now, there's no medicine that helps to grow back the beta cell or restore function to it. Once those beta cells burn out over time, they're gone.
Thank you so much for that added point as well. Does anybody else have any questions or comments they would like to include? Can someone have good fasting sugar and still be like insulin resistant? Like, I think in the presentation saying, you know, people sometimes don't, it takes a while to diagnose like hypoglycemia. Can someone have that, or what kind of questions should they ask their doctor? What kind of blood tests should they do if they have family history of it as well? You got the point. You got the point, Dr. G.
Fine, that's all Dr. G there. You're muted.
You're mute.
Okay.
It's okay.
So yes, there are screening tests, and typically just for ease of use, we do an A1C. That's a blood test, and that's a marker of what your sugars are running over a 3-month time period. It's more heavily weighted in the month prior, but it is like, I liken it to like the difference between taking a picture and taking a video of someone's sugar. So like a finger stick is if I take a quick picture of what's going on here and now with your sugar. An A1C is like I'm looking at a video camera of what's going on for those 3 months. And that's a good screening tool for patients. It's not perfect. Like everything, it's just not perfect. So patients that may have kidney disease or thalassemias or iron deficiency, the A1C can be an imperfect tool. Nonetheless, it's nice because the patient doesn't have to be fasting, and it's a simple blood draw. There is other screening tests called the oral glucose tolerance test that we use. I think most people are familiar with that test during pregnancy, but we can use that in such cases like women that may have PCOS, or if we're trying to detect insulin resistance a bit earlier, then I would recommend doing the oral glucose tolerance test, which is more cumbersome and requires the patient to come into the office and be there for a few hours and drink a liquid drink that's not really the greatest tasting. But that's a way to screen for diabetes. You can certainly do a one-time kind of blood glucose draw. That's another way to screen. And if it's greater than 200 with symptoms, that's diagnostic of diabetes. Your question about the fasting blood sugar being normal and the patient still having diabetes, absolutely. There are cases where patients go on drugs such as steroids. So we can see steroid-induced hyperglycemia, and that will predominantly affect the post-meal blood sugars. And so say the patient needs to take, their prednisone every morning for a transplant, or if they've had, lung disease or some kind of flare and they're taking prednisone every day, they take it in the morning and their sugars rise over the course of the day, and they get to be the worst typically after dinner. But then they self-correct overnight and their fasting comes down. So there are definitely situations where we can see that the fasting is okay, but they run high during the day. And so in those cases, doing the A1C or an oral glucose tolerance test is really helpful, because most people that don't have diabetes, they typically don't have a blood glucometer at home to be checking their finger sticks. And so we can do those blood tests in the clinic, or order it for their PCP to have done.
Perfect. Thank you so much. It's very helpful and for information out there for people to know. Hello, Dr. Pollywall. You're on mute, I think. Did you want to say anything or introduce yourself?
Yeah, this is Dr. Himanshu Paliwal, family medicine from Fairmount Clinic, Fairmount.
Thank you so much for joining. Any further comments or questions? You guys are going to have a lot more time on your hands here soon. Well, the only announcement I have today is that we have our next session on the 24th, and we're really going to try and get more cases in. So if you have any cases, we'd like to make that session more case focused. So we really encourage you all to maybe try to put some of those in, and then we can kind of just really enjoy that moment and go through some cases if that's okay. And then more information will come about that. Mitra, did you have anything else you wanted to add to that?
I think that was everything. Thank you so much.
Thank you so much again, everyone. I hope you have a wonderful day.
Thank you.
Thanks, guys.
Bye-bye.
Thanks, Sheree. Bye.
Thank
Thank you, Sheree.